Good day, everybody. Can everybody hear me?
Good morning, John.
Hey, how are you doing?
I'm ready. We are ready.
Oh, man, you're here early. Wow, you're gonna get a gold star.
You can see the background.
Yeah, very very nice. It's backwards to me. Like in other words, I can't read it. Let me see it again. Hold on. Yeah, it's backwards. It's I don't know how it can be fixed. You know, it's like you can read the neurosurgical, right? I can't read that.
I can adjust. Don't worry.
You know what I mean. You know what I mean, right?
Yeah. Let me try.
Okay. Okay, I'll be back.
Okay. Roots, you can see the background?
Let me see here. Hold on. Yeah, there it is. Okay.
Okay.
You can see it, right?
Yes, I can share.
Yeah. It's I don't know what you did, but you flipped it the right way.
You have also to put Firuz as a panelist.
Well, you know, we can have 100 panelists.
Oh, okay.
We've never, of course, come anywhere close to that. But I think someday, once this platform is used a lot, people will get used to it more, and there'll be more panelists. And I really think that conferences. Hello, Gothwan.
Hello, John.
Good day.
Good day. Good day.
Yeah, I think the conference is going to change to be more online and bigger. But we'll see. It'll go where it goes. You know, you can't control it. So did you get Dr. Kato oriented, Gautam?
Yes. The Kato is flying, I think.
Oh, okay. Yeah.
No, the other one, Dr. Kato. Sorry.
Yeah. Right. The last presenter, right? She's okay, Gautam?
Yes.
Good. Okay. Well, you guys are ready. You're here early. You know, we tried to televise Dr. Kato in Africa, but the connections weren't unfortunately very good. They were like Wi-Fi in Kenya. We just got a few presentations. We had a struggle. But, you know, we can all remember those days of low bandwidth with the telephones. I don't know if you guys are that old. Telephones as a modem. Really, really slow bandwidth. It brings you back to that time. Okay, I'll be back. I just got to do some last minute promotion.
Just, okay. Can you hear me?
Yes.
Good.
I can hear you.
I can't hear anyone. That's fine.
Try. You can see me. You can hear me.
I can hear you.
Yeah. Good.
No. Nothing in here. Nothing. 1 minute. I think. Yeah. Just speak. Yeah. I now you will not get. Okay.
Yeah. Too much.
I stop.
Send to you, Firuz.
Just mute yours.
Mute.
Oh, Binay. Where are you? How many you will put? Your cell phone.
No, it was not working.
And you've got your earphones.
You don't have earphones?
No.
Put your bloody iPods. So, how did you put this one? This background?
You have to go to preference, zoom out.
Okay. Preference. Share screen.
No, virtual background.
Virtual background.
I can send it also to you. You got Pedro.
What is the name of it?
Senza titolo.
Hmm?
Senza titolo.
Ah.
It's in Italian.
Okay.
You can hear me, huh? Gautam, can you hear me?
Yes.
Okay.
Yes. Yes.
Okay.
How to pick? I selected it. Then I need to. What I need to do?
This one. Oh, fuck this shit. Where is it? Not working with yours. Try to move back with your chair.
Yeah.
So, good.
We should have a bag.
With this one is better.
Yes.
Too much white, right?
Hmm? Now it became too much, right?
Yeah. Not good. You have to choose this one, man.
Yeah.
No way.
No way it is coming. I'm just checking out. That's it. That's it.
Something different. Now I don't sing. We can hear you singing.
Yeah. If I click share, this will come. My
If you click share, you share your laptop.
okay.
Hello, Benai, can you see me?
Yeah, I can see you.
Just stop sharing.
Everyone is trying.
You can start once.
Share, it will come up.
Yeah, you shared now already. Yeah.
My file.
Wait, he is sharing something. Sukro, you're sharing something?
Yeah.
Play it, na?
Okay.
Play. Play your PowerPoint. Right. Showing once, just leave it, na? Ricardo.
My email.
You are watching?
Yeah.
Watching?
You can see.
Wait, I will. Yes, if yours over, you stop it. Just check.
Okay.
Not echoing, no?
It's echoing. Everyone should put silent.
Yours over, huh?
Yeah.
Hi, everybody.
Greetings.
Hi, Professor Casoli.
Welcome.
Philip, can stop.
John, can you put the admin profile as a panelist?
Panelist. Is the profile of Professor Pavesi, the first panelist.
I stopped.
Yeah. Yeah, you got to, Ricardo, you have a good background. I don't know. I
Oh,
guess,
thank you.
I guess for Ruse, it's optional. Gotham, are you trying to get the background? Gotham, are you trying to get a background or no?
I'll be joining with Ricardo.
Just side of Ricardo.
Yeah.
I'm going to use my laptop. Don't worry. It's coming echo. That's why
It is coming echo. That's why I'm not joining. I'll cut my video now.
I'm not getting it.
Who's this?
Okay. Does everybody know how to screen share? Anybody need any refreshing?
Where is your PowerPoint
I
file?
think we are okay.
Okay.
Someone's getting an echo. Usually when you have an echo, that means you have another program open on your computer. You have another video open on your.
We've got 4 laptops in the same room. Maybe is this one the problem?
You decrease the sound fully. Mute
When
off.
there's an echo, that means
Decrease
you have
your sound.
2 audio inputs on your computer.
Then now?
No.
Also, I can hear you.
Yes, you should stop your completely here sound.
No. I can hear you also with mine.
After this?
So all you guys are fellows, right?
Yes.
No.
Wait, man. Where is your?
We gotta get that.
You can see the first panel.
Yeah, somebody has 2
Professor
programs
Pavesi.
on their computer.
You already joined.
Be me. Like sometimes it's me.
You can share. Click that. Share screen.
Siete in collegamento con
Il Giappone, con tutto il mondo.
You know, generally when you start the presentation, I would like for people to be able to see your face first before your PowerPoint. Do you know what I mean? And then you go to the PowerPoint after people see your face. Okay.
Ok.
Otherwise, you're just a little icon in the corner.
Yeah.
People really can't see
Saying
you.
what?
Yeah.
I'm to share.
Now I stop share.
Whatever you want to do, but I think it would be better to see your whole entire profile face. This is show business after all. Well, I got a big laugh.
Hello.
Hello, yeah. I don't know what. Let's see. You're given just a short time, right? 15 minutes.
Yeah.
Yeah, I don't know if it'd be a good idea to introduce everybody in every presentation. Do you know what I mean? So in the because of a time economy, we probably should just introduce you when you go on to your presentation rather than introducing everybody. Do you know what I mean?
A self-presentation, you mean? Self-introduction?
No. I'm just saying that we won't introduce everybody
Okay.
for every presentation. We'll just introduce the speaker.
Yeah.
Okay. Okay, we got a few minutes. Got about 11 minutes. Okay. The host is just getting out of surgery.
Where is gone?
Who is the host?
Warlix.
Okay.
Do you know Warlix, the neurosurgeon from Thailand?
Yeah, I do.
Oh, okay. I'm going to screen share.
Yeah.
She had some kind of case. I don't know what she had, but I think it was a minor case.
Okay.
Let me screen share. You probably know her. I think she's a 5th-year resident, or she's almost done.
Okay.
And I think she may even want to come to Japan to do like you guys, a fellowship.
Okay.
All your fellowships are varying length, right? They're not all 1 year or only 1 year.
They are like 2 months, 3 months, or 1
good.
month.
Oh, good.
Like that.
So it makes it easy.
Yeah.
It seems like a good part of your resume to go to Japan for a time.
Yeah, it is, John. It is. And it's a good experience.
Yeah. Yeah, I'm not a neurosurgeon, but I can see most of the big neurosurgeons have spent time in Japan.
Yeah, most of them.
Yeah, that was I didn't realize that until I got involved. Well, I didn't realize that you could do less than a year.
Yeah. It depends on places. Different places have different
Oh, really?
kind of, yeah. Some after 1 year, some for 2 years, others after 6 months, 3 months, 2 months, or even less than a month.
Yeah, you know, Ipcherian is starting some type of fellowship.
Yeah, he's already done, I think. There are more than 20 fellows who have come and studied.
Yeah.
I know that.
Neurosurgery coach.
Yeah.
From varying amounts of time.
Yeah.
Yeah, I was there with Ipe in Nepal. That was fun. He built a neurosurgery department pretty quickly with all the equipment and everything. Any of you guys been to Nepal, to Bharatnagar?
No, not really. I'm hoping to visit sometime in the future.
Yeah, he's a big proponent of cysternostomy. I'm sure you probably heard him at conferences. He goes to a lot of conferences and speaks.
He comes from the same place as mine, so I know him very well.
Oh, okay.
In the southern part of India.
Oh, not Chennai, Kerala.
Yeah.
Kerala.
That's where I'm from.
Vinod Felix is from there. You know Vinod?
Yeah, I know him very well. He just works across the street. So I know him
you're
very
kidding? He lives that close?
Yeah, he lives very close. I know him well.
Yeah, he's very active.
Yeah,
He goes with Ipe in Bharatnagar.
yeah, he does. I've
Yeah.
seen him.
Yeah.
There are
Very-
very few participants today, only 7. What happened today?
Yeah. So is Kerala is on the ocean, right? On the Indian Ocean.
Yeah, Indian Ocean, southern side.
Oh, okay.
Arabian Sea. Arabian Sea.
Is that
One
considered a
side is-
vacation area, southern India?
Of course it is. Of course
Is
it
it?
is.
Is it
Yeah, it is called the God's own country.
Godsun?
You can on God's own country.
Oh, really?
Yeah, you search for it in the internet and you'll get to know a lot about Kerala.
Oh, okay. No, I see the name popping up.
Yeah,
And Goa. Is it near Goa or Goa is north?
yeah. Goa is a 1 hour flight from here.
Oh, okay. So it's not too far.
1 hour and 15 minutes.
Very good.
Yeah,
Okay, I'll be right back. Let me check with Warlith.
yeah,
I'll be right back.
sure.
No, no, ma tu lascia stare. Perché...
Non capisco, no, stavo cercando di capire come faccio a muovermi, se posso muovermi tra un quadro e l'altro, perché posso selezionare chi voglio.
Riccardo, siamo a posto? Non è che si vede bene.
Sta ridendo. Cazzo, adesso io scrivo.
Tu ridi?
I see Dr. Pavesi is there. Hello, Dr. Pavesi.
Yeah, I'm here.
How are you, sir? I'm a very good friend of Alberto Felletti.
Ah, okay, I see.
So good to see you, sir, here.
Thank you very much.
Yeah. Yeah, I think Ricardo is one of your students, I think.
Yeah.
Is the former resident?
Yeah.
Yes, I am.
Yeah. It's good.
And ending neurosurgeon.
Hey, Ricardo, good to see you. I hope you are having a nice time. I hope you are enjoying your stay in Japan.
Yeah, it's quite good. It's quite good.
It's a good
Someday
place.
without madam, so it's good.
So
As you know.
surprised. Yeah. It's a bonanza to go out.
Yeah.
Right. Good. I don't think we are starting because it's already 3:30 here. We are beyond time.
Do we have to
Waiting
start?
for some panelists. Maybe.
What do you say, Dr. Binoy? Should you take over?
No, it's okay.
Another 3 minutes.
Okay, well, right.
Advertising time.
Yeah, we can see a trailer of Star Wars or something similar if you want.
Okay, you guys know all about the mute button, right? When you're not speaking, you gotta mute yourself. Okay, that cuts down on the background noise of wherever you're at. But of course, when you speak, remember to click on the unmute. And other than that, just keep all programs off your computer to make noise. And Giacomo Pavesi is the first speaker, right?
I'm here.
Okay, good. You're first, right?
Yeah, can you hear me? Yeah.
Yes, very good.
Thanks.
I like your background. It's
Yeah.
real. It's real. The real neurosurgery.
It's the room of the on-call guy.
Okay. That's not a photo, right? Okay. Let's see, I guess.
In effetti siamo gli unici a essere in ospedale, probabilmente.
Sì, perché gli orari sono sbagliati. Ma in Giappone sono le 6 di sera.
Sì, non è tardissimo.
Okay, I guess Warlith is, she couldn't get out of surgery in time, but I'll just do the first one, I guess. But okay, we're about to start. Okay, Giacomo, just less than a minute.
Ok. Tu sei pronto?
Sì.
Però partiamo con la faccia.
Così.
Okay.
Sì, sì, già con la faccia, prof.
Ah, sono con la faccia?
Yeah.
Sì, sì,
When
vede la faccia.
when I introduce you,
Vedeva la
Giacomo,
faccia, adesso si vede la presentazione.
yeah, when I introduce you, please get off the screen share.
Ok.
Okay, we're ready to start. You ready? Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day. This is Dr. John Bennett broadcasting from Miami Beach. We have the third Japanese symposium today, and we'll start right off with our first speaker. Let me introduce Giacomo Pavesi. Go ahead, Giacomo. Please introduce yourself and go on with your presentation. And welcome.
Thank you very much. We are speaking from Italy, in Modena, which is a town in the middle of Italy, and it's a very nice day with sunshine. You can see the light coming from the window, and we are very glad to participate in this webinar, and very thankful to Professor Kato, who invited us to speak about cerebral aneurysm. And I think we can move to the presentation.
Okay.
Okay. So we are going to talk about the treatment of unruptured aneurysm and about the middle cerebral aneurysm in particular, because the question is if they are always a microsurgical matter. I mean, if they have to be treated by microsurgery alone and not endovascular means. So what is the question and what is the answer? Of course, middle cerebral aneurysm are frequently a microsurgical matter, but not always. And this is why they are so various in morphology and in location along the middle cerebral artery. So they are a very various type of aneurysm, very different one from another. And of course, the prevalence of intracranial aneurysm is much bigger than the number of aneurysms that rupture. And we know that 1 year mean risk of aneurysm rupture is rather low, especially for small aneurysm. And we have to look at the risk of their preventive repair, either surgical or endovascular, because we have to balance it with the risk of rupture. And many prognostic factors for aneurysm rupture have been proposed. And we have some guidelines that aim to size, location, morphology, or documented growth of the aneurysm, and the patient-related factor as age, history of previous SAH, or family history, the presence of other aneurysm and conditions that predispose to higher risk of hemorrhage. So we have some prognostic factors that may lead us in the choice of treatment. And efficacy scores have been developed for the prediction of risk of rupture, and this entails some important factors like hypertension, age, the size of aneurysm, of course, and the presence of other hemorrhage before and the site of the aneurysm. And the guidelines are not so clear-cut, and we can reach a conclusion that it may be reasonable to choose endovascular therapy for a selected unruptured aneurysm when surgical morbidity is high, and this is for basilar apex or elderly patients. In the other cases, the option of surgery or endovascular is not so clear. MCA aneurysm are a very frequent one, and they are about 40% of all intracranial aneurysm. They have a peripheral location, which is very superficial to the cortex. So, and the wide neck incorporates the origin of one or both M2 segments. These are the reasons for because they are so considered a surgical matter. For this configuration, they largely remained in the domain of surgery. However, endovascular therapy is still increasing in indication and in options, also in MCA aneurysm. And there are a lot of series that have been published in aneurysm of the middle cerebral artery that shows that surgery is very, very successful with a very low morbidity risk of procedure. So this is because now we approach these aneurysms with a very, very small and targeted approach, which entails just a very few millimeters opening of the Sylvian fissure, and a safe clipping can be made without a very big surgical exposure. This is for unruptured and small aneurysm, of course. In a way, we went through our caseload of unruptured aneurysm, and we saw that MCA aneurysms are the most frequent ones, and besides, they are also the most frequently associated with morbidity. So it is true that they are easily accessible, but it is true also the contrary, that they are not so easy to clip without damage. In our series, they were the most commonly associated with morbidity, MCA aneurysm. So they are very risky. It's a very risky location, actually. And open microsurgery, from what comes from the literature, should be considered as primary treatment due to its high occlusion rates and low complication rates. And endovascular therapy should be administered in elderly patients or significantly calcified aneurysm wall, or when the aneurysm geometry is more favorable for endovascular rather than surgery. And a meta-analysis that has been published in 2018 in neurosurgery confirms that MCA surgery continues to be a safe choice, even if endovascular has lower rates of occlusion, we can conclude. Which are the main surgical complications I was telling you before? They are entailing perforatory injury, which is the most risky, arterial branch occlusion, damage to the venous system, or brain contusion during dissection. Of course, we have means to improve our results, and they comes from technologies like flow probes, intraoperative flow Doppler, indocyanine green angiography during surgery, intraoperative digital superfraction angiography, which is available if you have an hybrid operative room like we have the luck to have. And motor evoked potential in some selected cases may be very, very useful. So these are the means of technology that now we have to have when we give indication for these operations. And in our series, we have 51 unruptured MCA aneurysm. And so we went through some cases to show the difficulties we have encountered and the problems that you may meet during these cases. The case one is a male, 64 years old, who presented with transient left hemiparesis and aphasia. And he had two unruptured aneurysm, one partially thrombosed right MCA bifurcation, one right ICA bifurcation. What to do? In these cases, you can see the CT with MCA partially thrombosed aneurysm, and then the reconstruction of the 3D angio-CT. DSA to complete the diagnosis, and the patient was brought to surgery, and we look at this illustration depicting the thrombosed part of the aneurysm and the active part of the aneurysm on the MCA. And this is the post-op control. This was a very successful cases for surgery. And case two, female familiarity for unruptured aneurysm, transient amnesia, CT scan, multiple aneurysm. And you can see these are incidental diagnosis of cerebral aneurysms, multiples. The choice is very difficult, but in this case, we approached the MCA aneurysm on the left, and it was cleared because it was very favorable to do it. And you can see the angio control intraoperative, and the postoperative course was fine. And the other aneurysm on the perical locus, we prefer to and go to the endovascular, not to have a second craniotomy. And for what concerns the right MCA aneurysm, I think we will offer the patient a second surgery on that side. That's how we think about it. Case 3, male, 72 years old, family history of subarachnoid hemorrhage, hypertension, incidentally discovered left MCA after a head trauma. You can see the aneurysm is not big, it's broad-based. It is considered a very low risk of hemorrhage aneurysm, but she has some risk factor that considered. Generally, we went to decide for surgery. She had a transient aphasia, maybe linked to the manipulation of the temporal lobe, and the good recovery very soon. But after 3 months, she had a partial seizure, and she came with this CT with a subdural chronic hematoma that was treated conservatively, and 6 months later it disappeared. So we have to follow up these patients for a long time. And this case is 80 years old, male. He had a first operation on 1994, clipping for an MCA aneurysm. At 2004, the CT scan was negative. And then he had a syncopal episode. Clinical examination was negative. And in 2012, he came with a CT that showed a large aneurysm at the MCA bifurcation. And this is the case, and this is very interesting because it was clipped a long time before, and it was very good clipping, but in the years, these aneurysms regrowth, and you can see the regrowth of the aneurysm at 18 years from surgery. The aneurysm regrowth on a weak side of the clipping, and this is the DSA. And this was a very complex operation. This is an illustration of what we have found and how we treated this remodeling of the new aneurysm. And this is the post-operative CT scan. He had a transient left hemiparesis that solved after a few weeks. Female, 33 years old. She had a subarachnoid hemorrhage in 2013. She had an operation elsewhere, and 5 months later, she came to us with an acute headache, and the CT scan and DSA showed a residual aneurysm. What to do? This is very interesting because it's a redo operation on an elsewhere than clipping. Partial clipping, as you can see, and it's very difficult to make decisions about this because these are very risky. But if you look carefully at the angiogram, you can see that the aneurysm filling from an anterior temporal artery that goes straight inside the aneurysm. So we decided together with the endovascular fellows to coil this temporal artery and exclude the aneurysm without damaging the flow on the MCA artery. So this is the final result of occluding with a little bit of coil the sac. And this is the post-operative course. And she had an uneventful recovery. And this case it's another different kind of MCA aneurysm, left hemiparesis, intermittent headache, and psychomotor impairment. She had a giant serpentine MCA, partially thrombosed. What to do? This is the case. This is very big thrombosed serpentine giant aneurysm, and you can see calcified walls, and the involvement of both temporal and frontal artery from the MCA. So what we have done is a partial embolization in order to reduce the flow inside the sac, and then go for surgery directly the day after. And this is what we found. This is another illustration. You can see the big aneurysm, the M2 temporal artery and the M2 frontal artery coming from the base of the sac of this giant aneurysm. So we cut the branches and made an anastomosis between M1 and M2, while the M2 flow was considered intraoperatively with indocyanine sufficient to irrorate the brain. And this is the DSA post-operatively. You can see a small clip where we closed the outflow of the frontal branch and the reconstruction of M1 and M2. The pointer is on the side where we made the anastomosis. She had a left hemiparesis and frontoinsular ischemic area that we couldn't prevent totally, but I think that with the anastomosis we prevented a large brain infarction that would have her to suffer for all the hemisphere. So at 1.5 years, she has this ischemic area, but she is improving. She can walk. She of course she has a slight hemiparesis. And case 7 is 73 years old with anticoagulation therapy and transitory right nerve fascial palsy, dysarthria, incidental MCA, bifurcation aneurysm. What to do? This is the case that is very impressed in our mind, because this small aneurysm, 73 years old, and of course, guidelines says that maybe it's not that at risk. The only associated factor was anticoagulation therapy and hypertension. And this aneurysm is not so easy for a surgery, because you can see almost the fusion of one branch on the side of the sac. And this is what happened during surgery. She had a hemorrhage on the base of the neck of the aneurysm, and during clipping maneuver, we had to sacrifice a perforator. So she had this, after surgery, this CT, and she developed and left hemiplegia because of ischemic injury on this perforator with the ischemic area that you can see on the 2-day CT scan. So this is follow-up at years, but she remained with a very severe deficit. So these are scary malformations, and they carry an intrinsic risk of damaging if surgery has some periprocedural trouble. So they are not so, they have to be looked very carefully and to consider the risk of treatment. We thank you very much from Italy, and see you soon.
Okay, thank you very much, Giacomo. Do you have any questions or comments from the panelists? Or we're pretty tight with time, I suppose. Okay, Giacomo, I hope you continue to participate in these webinars. Okay, we need to get off. Let me get you off screen share there. Okay. Yeah, there we go. Okay, very good. Okay, we'll move on to the next presentation. And I'd like to introduce Raja Kuti. He's going to talk about evolution of aneurysm surgery from past to present and future. Welcome, Raja. Could you please say a few words about yourself?
Hi.
Welcome.
This has been a great opportunity for me to share the dais with one of the greats, Professor Miho Kukato, and as well as Dr. Bavesi, and all my friends who are my earlier fellows and colleagues. So I also would like to thank Professor Kato for inviting me for this webinar. So I would just start my webinar right now. Can you please share my screen?
You need to share. There's the option to share screen. Yeah.
Yeah. This one.
Yeah. There you go. You got it.
Yes. There we go.
Yeah. You guys see me?
Yes.
Yeah. There you are. So this has been a huge topic. So it is very difficult for me to limit within the confines of time, but I'll try to do justice to my job. There you go.
There you go.
So earlier on, this was considered. Aneurysms were considered not as surgical candidates. Where earlier times conservative management was supposed to be the best, and then during times of Harvey Cushing, once he phrased that regarding aneurysms, he told that a lesion having such a remote surgical bearings, whether there are any surgical indications, further experience alone can tell. From those times to this, today we have come a long way forwards. The earlier decision for surgical indications were mostly based on ligation of parent arteries for peripheral aneurysm, which was pioneered by John Hunter. Later on, Ashley Cooper in London applied this technique to treat cervical aneurysm in 1805, but the patient died a few weeks later. Whereas in 1808, Cooper proceeded on second attempt and successfully treated a pulsating tumor at the angle of jaw. Earlier reports of aneurysm exposure were rather serendipitous discovery than planned approach. This was done by Victor Horsley in 85 as well as in 1902 when he performed a carotid ligation, which was in fact an aneurysm of the ICA. William Halstead promoted the idea of fractional ligation instead of complete ligation, which paved the way for surgical clamps like Dot, Stretchfield, Silverstone's, Kind and Drake vascular clamps, which are almost obsolete now. The Hunterian principles paved way for the surgical trapping. Axel Herbert Olivicrona performed the first successful unplanned surgical trapping and excision of large pica aneurysms, followed by Dandy in 1936 and 1944. Dandy was credited for performing the first VA ligation beneath the atlas to treat a vertebral aneurysm in 1944. The vertebral ligation and trapping were also used during this era for the treatment of vertebral and as well as basilar aneurysm because of the high morbidity resulting from direct surgery to the pica posterior circulation aneurysms. The beginning of direct surgery for intracranial aneurysm started in the 1930s when this was first attempted by Sir Norman McComish Dot, who wrapped the aneurysm with a piece of muscle taken from the patient's thigh. And during this period, other surgeons also established their own direct surgery on the aneurysm using muscle wrapping technique like William Tawny's, Adam McConnell, Dutton, and Silverstone. The first awake Hunterian ligation for treatment of ruptured basilar bifurcation aneurysm, performed by Dr. Charles Drake in 1975 at hospital in London, Ontario, Canada. Drake's initial notes suggested that he did not think that the small PCOM arteries could support the circulation of the top end of the basilar artery. And in his note, he wrote that this is the first time temporary occlusion of an intracranial artery has been carried out in a patient who is awake to test the collateral circulation. And I think it may be forerunner of many more. Now, this case has a very important landmark in the history because this patient had a recurrence of the aneurysms almost 35 years later, when it was treated by total endovascular method. And during that endovascular treatment, the patient had a carotid dissection, and during which a stenting was also done. This was beautifully reported by Binding et al. In this titled "The Testing Boundaries of Neurosurgical Inversion Twice." This is a very good article. I would recommend everyone to read. Then came the era of clips. In 1911, Harvey Cushing produced what was to become the first vascular clips, known as silver clip or Cushing. He never used this for aneurysms, but rather for vessel manipulation during tumor surgeries. In 1937, Walter Dandy used Cushing clips to clip a IC PCOM aneurysm. What followed was the start of the modern aneurysm surgery. Dandy continued direct surgical clip ligation and collected a large patient series. In 1944, he published the first monograph describing aneurysm surgery, intracranial arterial aneurysms. The clips underwent many refinements in the years to come. Olivicrona and Noren placed wing blades that enabled the reopening of clips. Earlier, Cushing's clips were not be able to be manipulated or reopened. Then came other clips like Frank Mayfield and Key's clip. And then the Drake's fenestration clip was born out of necessity in 1969. The fenestration was largely to accommodate the adherent P1 while clipping a basilar top aneurysm. Then came the Lockheed Kerr clips, and these clips were lightened the closing pressure of the aneurysm, which enabled them for the temporary clipping of the parent artery. Then later came the Sun clips, which were for encircling graft clips, which is a pivot type clip consisting of metallic spring that applies pressure on a Teflon or a Dacron graft. Now, these clips even used today, allowing reports of aneurysms such as broad neck aneurysm, blister aneurysms, and major vessel tears that required prompt intervention. There were other newer clips that became popular where the Yassergill clip, the Fujita clips, and the Spessler's clips. Spessler's clip was the first from the BNI, Sir Robert Spessler, who from the BNI first tested the titanium clips in animals followed by humans, and that later on became the standard of care. Now all the clips what we use in modern era are made up of titanium. These are the few clips that came in evolution: the Dandioli, Corona, Mayfield, Drake, Effie's, Logit curves, and the Sun clips. In 1965 came another method of trying to tackle the problem of aneurysms known as the electrothrombosis. Now, this was an entirely different method where Alkins John embolized the ACOM aneurysm with magnetically guided iron microspheres injected directly into the aneurysm dome thanks to a probe which was stereotactically positioned. The magnet was fixed to the skull for 5 days, and the time necessary to allow the blood to clot and to reorganize sufficiently to prevent subsequent disintegration and thus distal dissemination of the iron particles. This is the description of that technique, but this has become obsolete as of now. And this was similar to people who tried electrothrombosis. Yoth in 1961 upgraded the same technique using platinum cobalt magnet. The era of microscope started in 1960s, and this changed the field of aneurysm surgery forever. Kruse was the first neurosurgeon to use an operating microscope in the surgery for intracranial aneurysm. Nevertheless, the microscope was not reported as an adjunct to aneurysm surgery until 1966, after which Yassergill is widely credited with the popularization of this approach. Following publication by Logit, Marshall, and Yassergill in 1969, microsurgery swept through the discipline of neurosurgery and quickly became the standard of care for intracranial aneurysm. For the first time, vascular neurosurgeons could effectively illuminate and see the aneurysm. Perhaps the greatest impact of the operating microscope was not just it enhancing the results of the experienced aneurysm surgeons, but also there was a steep learning curve for the young neurosurgeons to achieve competitive results within a short period of time. The clipping surgery for anterior circulation found many advocates, but there are not many takers for the posterior circular aneurysm. Now, Charles Drake adopted the use of operating microscope in 1971 and contributed greatly to the understanding of the posterior circulation aneurysm. In a 40-year span, Drake, along with Peerless and Ernest Niami, published a monograph of unprecedented and since unmatched series of 1,767 VA basilar artery aneurysms, which they amassed over a 40 years span. Bypass for extracranial to intracranial came in was first tried in 1961, where a synthetic graft using a plastic tube was tried to create a bypass between STA and the ACA as a shunt. Arteriography performed less than 2 weeks after the operation showed a clotted tube. However, the patient apparently recovered well and was able to return to full-time work. This was followed by 1963 when Warringer and Kunlin performed the first extracranial to intracranial bypass. But unfortunately, the patient did not survive. But the saphenous vein graft they used during this surgery was found to be patent during the autopsy. In 1969, Yassergill described the STA to MCA bypass for the management of complex aneurysms. And this became the standard of care not only for the complex aneurysm as well as it became a lifeline for Moyamoya disease and other vascular pathologies. It has become an important technique only to be mastered by a few, and young neurosurgeons should come forward and learn these techniques sooner than later. In 2003, Andre Rabe and the team of Barrow introduced the ICG into vascular neurosurgery. Today, no high-volume center is complete without ICG as an adjunct to aneurysm surgery and has become the standard of care. The endovascular era cannot be looked upon down. Since 1927, the neurology professor Igas Moniz described the first cerebral angiography, and following what became a landmark for the beginning of endovascular era. Now, earlier it was used by blood flow the navigation was guided by blood flow. Then magnetically guided devices, among others, made their appearance, followed by the modern microcatheters equipped with guide wires, which finally allowed negotiating arterial bifurcations. The concept of using balloon to treat cerebrovascular lesions was inspired by a 1959 May Day celebration in the Moscow Red Square, where this gentleman envisaged the taking cue from the watching children who were manipulating and using helium balloons. This gentleman, further Serbinenko, a Russian neurosurgeon, began to envision small balloons moving through the tortuous artery. And in his attempt to devise a balloon catheter, it took him 9 years to come to his experiments, to see his experiments a success. In 1985, Braun reported the first intracranial aneurysm treated with coil embolization. Interestingly, the use of coils in this setting was the result of an unsuccessful balloon occlusion for a giant IC aneurysm. The introduction of platinum coils with dacron fiber to induce thrombosis for the treatment of vascular malformation and aneurysm was reported by Hilal et al. In 1988. A controllable delivery system with the ability to retrieve, reposition, and redeploy the coil to a satisfactory configuration prior to detachment was necessary to increase the safety of the procedure. Guglielmi first constructed a microwire with small magnet that would be introduced endovascularly within an aneurysm. He then developed a technique whereby a suspension of iron microspheres would be injected into the circulation and be attracted to the small magnet within the aneurysm, thus inducing thrombosis. The magnet would then be electrolytically detached from the microwire and left in situ. Then he began to work with Ivan Spetska of Target Therapeutic and developed the first generation electrolytically detachable coil, where he first coiled a traumatic cavernous fistula. Following a month later, he coiled the first aneurysm with those coils. The CFDs came into practice lately. If you go through PubMed and search, there has been a flurry of articles published in the late 2018, 19, and 16 regarding CFD and aneurysms. The endoscopic era was not until 2006 when Amin Kassim clipped a giant VA aneurysm which was previously treated by endovascular technique. This case was reported to follow an array of publication, but however, lately there has been a slump. There was a few articles published in 2015 and 16, and followed by that, there has not been much of enthusiasm. This is a timeline of events for all the things that happened during the evolution of aneurysm surgery. The giants, modern day giants, cannot be forgotten as of today. Robert Swessler, Professor Sano, Professor Yoko Kato, Professor Lawton, Professor Takizawa, and all who have lived through the legacy of through the work of Professor Yasser Gill. The future, of course, it is in the safer hands. So bypass has to be learned by there is the first generation, second generation, and third generation bypasses, and one has to master these techniques. Dexterity remains the magic that makes microsurgery happen. However, the mastery of a vascular neurosurgeon comes from the head and the heart, thinking through the right strategy and the best solution, and then striving to achieve perfection. Instruments following commands under the microscope is the greatest gift that has to be earned through repeated maneuvers. No matter how far the endovascular neurosurgery advances, some aneurysm will need to be clipped. And these are the great words of Professor Michael Lawton. With that, I would like to end my talk. I hope you had a great time, everyone listening.
Thank you very much, Dr. Cutty. Any comments or questions from the panelists? Let me get you off the screen share. Okay, I'll just take you off there. Okay, very good. We hope you continue to participate, Dr. Cutty. Very interesting presentation.
Definitely. Thank you very much, John.
Thank you. Okay, we'll continue on with Ricardo Stanzani. He's going to be talking about early rescue bypass surgery for acute coil migration. Welcome, Ricardo.
Thank you, John. Good evening, everybody. Good morning for you who is in Europe. My name is Riccardo Stanzani. I am a 50-year resident of neurosurgery in Italy from Padova University, and I work in Modena Hospital with Professor Pavesi. So I start to share my PPT. Wait some second. Okay, can you see?
Yes, very good.
Okay, so today I'm introduced to you a case of acute coil migration treated with the STA-MCA bypass. A 62-year-old woman with an unruptured left intercavernous internal carotid artery aneurysm underwent balloon assist coil placement. The aneurysm seemed to be completely embolized, but after balloon deflation, the coil migrated. You can see that the migration caused a significant occlusion of M3 branch with severe reduction of flow. Better see in these zoomed images. And this is the 3D reconstruction, where in red, we can see the M3 branch where significant reduction of flow was evidenced by DSA. So what to do? Actually, consensus does not exist regarding the best retrieval technique for migrated coils. Ding et al. Review management strategies for intraprocedural coil migration, in particular with regard to endovascular retrieval method. In the English literature, we can also find some case report of surgical removal of migrated coil, like in Deshmukh and Motegi work, and some paper like this one from Lee about bypass surgery in delayed stent thrombosis. Abdelkader et al. Report 18 cases of coil migration and propose a consensus-based algorithm for the management of migrated coils. As you can see, for distal localization, they propose to consider medical treatment. Coming back to our patient, migrated coil was too distal to try to retrieve it with the endovascular tool. And they were too deep, and the occluded vessel was too small to perform surgical removal of the coils. After early clinical deterioration with a ZCS score from 15 to 14, we decided to perform bypass to restore cerebral perfusion distal to the occlusion. We can see the intraoperative video, accurate left STA dissection. Dura was opened after performing a small frontotemporal craniotomy. ECG check was done before bypass, and we perform also 800 flow, as we can see. The receiving MCA branch was identified and dissected. We then prepare the donor vessel and the receiving vessel. And then the bypass was performed. After performing bypass, we perform ECG check, 800 flow again, and Doppler check that confirm the patency of the bypass. We can see on the left side of the slide the 3D reconstruction after post-op CT angio. And on the right side, we can see CT angiography perfusion. Shows a hypoperfused area, the more blue one in this point, in the frontal lobe, middle and inferior gyrus with low CBF and with preserved CBV. The patient woke up in intensive care unit with no motor and language deficit. The following postoperative course was uneventful, and she was discharged at home 7 days after the surgery. So what is the take-home message of this case? Coil migration is a rare complication that could have catastrophic consequence. The bypass should be a successful rescue therapy in selected cases. Someone may claim that the patient could recover also if STA-MCA bypass was not performed. No control study has been conducted to the date, and probably is not possible to do something similar. But we can only speculate that it is very presumable that a significant occlusion of M3 branch will become symptomatic. So ultra-early treatment was preferable to try to lead a better outcome for the patient. Thank you.
Okay, very good. Thank you very much. Any comments or questions from the panelists? Go ahead.
Yes,
Go ahead.
I have one.
Go ahead.
Yeah. I wonder why the patient was elected to treatment, because it's an intracavernous small incidental unruptured aneurysm.
Good question. Good question. The patient discovered the aneurysm in 2011, and on serial CT scan, the aneurysm growth. Patient has got also familial history for subarachnoid hemorrhages, so they decide to treat the aneurysm by endovascular treatment.
Okay.
Very good. Marco from Lake Como, welcome. Do you have any comments or questions?
Hi, guys. No, it's absolutely an interesting case. I appreciate a lot the technique of bypass. Just my best congratulations for all the Modena keep.
Very good.
Modena keep.
Okay, thank you very much, Ricardo. We're going to move on to the next presentation. Dr. Gautam is going to present computational flow dynamics in aneurysm surgery. Welcome, Gautam, and can you please introduce yourself, tell about where you're working, etc., and on to your presentation. Thank you.
Hello, everyone. I'm Dr. Gautam. I'm practicing in Chennai since last 5 years. I have done my post-graduation in voluntary health services. And presently, I'm a consultant in Dr. Rela Institute and Medical Center. I'm going to start my PowerPoint.
Very good.
Can everyone see it? See
Yeah,
my PowerPoint?
Looks great.
Yeah. Today, I'm going to speak about computational fluid dynamics in aneurysm surgery. And what is computational fluid dynamics? With the aneurysm is all the blood vessels are taken as a tube, and the aneurysm as a swollen thing in the tube, and we want to see the what are the dynamics of the blood flow, like how the blood is flowing, what are its effect on the wall, and how there is a chance of any rupture or not. These studies has been started since long back, since last 15 years. There has been extensive studies has been going on, but still there are no clear consensus like why what is the hemodynamic changes, and whether they are coinciding with aneurysm. So studies are going, multiple studies are going consequently. I am just describing today we are what are our findings in multiple cases, and what is the model of the growth of the aneurysm. What is CFD? It is the thing where aneurysm, where the images are 3D reconstructed, and a computational mesh sequencing is given, and then boundary calculations has been done, and computation, and then visualization is done, and with that we get some parameters. The most common parameters are the flow, streamline, wall shear stress, and velocity. The new techniques, why CFD mechanotransduction? Endothelial cells, they sense the wall shear stress. It is a frictional force between the blood and the vessels. Because of these wall shear stress, there will be multiple changes in the aneurysm. But the main drawback of the CFD is these things are taken at a single point of images. These are not continuous. There are no studies with continuous CFDs in patients. So the common variables are velocity, pressure, auxiliary shear index, and wall shear stress. So this analysis has been applied to risk analysis of the rupture of the growth mechanisms in cerebral and unruptured intracranial aneurysms. So what is wall pressure? This is the pressure exerted by the blood on the wall, and there are in this multiple variables are there. That is the most common thing. What many studies show is pressure, instantaneous pressure, which is also called as Pmax. And the Pmax was calculated as the highest area of the pressure at the aneurysmal wall, both spatially and temporally. It was color coded. The blue is less pressure, and the red is on a higher side. This is an example of an aneurysm which has a more of a high pressure. The next parameter, what is most commonly seen, is the pressure difference, and it was defined as the degree of the pressure elevation at the aneurysm wall at Pmax area by subtracting P average from the Pmax. In this aneurysm, this is the same aneurysm at the top top of the sac. We can see the pressure variable, which is significantly high. And the study by Suzuki et al. They have studied this Pmax and P variable and concluded that the areas with the Pmax and the P variable has the potential to develop changes in the wall and causing bleps, which is most commonly because of the apoptosis. Coming to the next mostly studied parameter is the wall shear stress. It is the frictional force between the arterial wall and the blood flow in the direction towards the local tangential. Multiple studies were done. There are still no clear evidence about the wall shear stress. Most of the studies have been mixed with unruptured and ruptured. And while comparing the unruptured aneurysms, the wall shear stress seems to be low in the ruptured aneurysms. But this is there are no, still why the wall shear stress decreases is not clearly evident. So there are both the theories of low wall shear stress and high wall shear stress proposing related to the ruptured aneurysm. So the next parameter is the oscillatory shear index. It is the directional changes of the wall shear stress during a cycle, during a cardiac cycle. The more the changes like diversion and convergence, if it is greater than 90 degrees, the oscillatory shear index will be more seen. There are reports like higher oscillatory shear index associated with high pressure difference. When both are there, that means that there is significant vector differentiation and there is high pressure. This causes rupture. And the high oscillatory index point is corresponding to the rupture point. Coming to the vectors, this is a aneurysm, two aneurysms I am showing with areas of diversification. This is one area of diversification. This is another aneurysm with the area of the diversification. These areas tend to be the area where there is significant sudden change of the blood vectors. And this is the area mostly associated with high pressure differentiation and formation of the bleps. And this is the other area with vector convergence, and these areas where we see the blood goes and forms a stagnant region. When the this area generally corresponds to the inflammatory development of inflammation, because once the blood is stagnant, there will be endothelial expression of the nitric oxide. Because of the endothelial inflammation signs will develop, and the atherosclerotic changes correspond accordingly. Coming to the next parameter is streamline flow. It gives a clear idea about how the blood flows in the aneurysm. It gives about the development of the recirculation flow in an aneurysm, and also it gives the velocity of the flow. It gives a pictorial diagram. In this is the aneurysm. We can see the blood is coming in a high velocity at this region. At the wall where it is development of the recirculation, we can say there is a moderate velocity is on a moderate side. And once you come to the opposite side, once the recirculation flow continues and development of the complete recirculation flow near the center, it is almost zero. So this gives the flow patterns of the blood along the velocity comparisons. So Meng and et al. They have concluded like intra-aneurysmal flow, aneurysmal geometry, and pathobiology as three different factors and associated. And there is a development continuously aberrant hemodynamics, growth, repair, and degradation. When there is imbalance, then there will be a degradation and destruction. This is the high combined theory proposed by Meng and et al. In which once there is a high wall shear stress, there is endothelial sensing and mural cells producing MMPs, and apoptosis develop, and thus leading to the internal elastic laminar damage and media thinning. Formation of the aneurysm develops. Once the aneurysm develops, there are two mechanisms. Once the aneurysm develops, the mural cells producing, if the high wall shear stress still continues near the impinging flow, So there will be matrix degeneration and mural degeneration occurs, and thus forming a possible bleb at that level. This is the mural cell mediated pathway established by them. The other theory is once there is a development of aneurysm, the flow starts decreasing and the speed decreases, and there are pro-inflammatory endothelial cells develop, and the blood cells resident time increases, and thus inflammatory infiltrates develop, and there will be atherosclerotic changes. Once the atherosclerotic changes develops, there will be inflammatory infiltrates, and due to changes in the wall, due to changes in the hemodynamics, there may be increase in the size of the aneurysm, or there may be a rupture at the edges of the aneurysm where the atherosclerosis is there. And if these things are the dynamics, everything are stable, it may continues to be hyperplastic remodeling, and the aneurysm wall starts becoming thick. This is the thing by this is the article by Furukawa, and they have mentioned like in a bleb of aneurysms, aneurysm with multiple blebs, they have given hemodynamic characters of hyperplastic remodeling, and they have proposed that in this aneurysm we can see this is the impinging point at one aneurysm, and the other aneurysm is having a significant low wall shear stress. And this is a review of the literature was done by Murayama et al. Recently published in Neurosurgery Focus. They have taken all the literature review of Castro et al. Where the wall shear stress was the high, and it has a small impact zone. This is the only study which they have showed, but there are all studies showed low wall shear stress as a significant factor. But the recent studies which show that we have been continuing, the pathological studies are going on, and CFD studies, when done preoperatively, give an idea of aneurysmal wall anatomy. High pressure difference along with vector diversification and high wall shear stress corresponds to the area of development of a new aneurysm or bleb formation. Once the aneurysm develops, when the aneurysm develops and the recirculation flow develops, the wall shear stress slowly decreases, and remodeling occurs depending on the flow in aneurysm. And high oscillatory index and convergence correspond to stagnation and inflammatory destructive remodeling. Flow gives pattern in the aneurysm flow, and gives an idea about the recirculation flow in the aneurysm and the blebs. Blebs associated with high velocity in streamline and a high pressure difference tend to be thin and tend to be rupture. Thank you for your patient hearing. Thus we conclude.
Very good. Thank you, Gautam. Thank you for participating, and thank you for helping put the webinar together. Any comments or questions from the panelists? Okay. If not, we'll continue on with the another presentation by Dr. Farouz on anterior wall aneurysm of the internal carotid artery. And Dr. Farouz, could you please introduce yourself, tell where you're working, and welcome. Thank you for coming.
Hello, John. Hello, everybody. I am Dr. Firuz Shukuru from Uzbekistan. Now I'm a fellow in the Fujita Health University Bantani Hospital. I'm going to present a presentation about anterior wall aneurysms. Can you see the screen?
Yes.
Okay.
Perfect.
So today I'm going to present about anterior wall aneurysms and the correlation between computational fluid dynamics change and intraoperative findings in these aneurysms. As we know, anterior wall aneurysms has been well known as a strange and dangerous aneurysm that easily ruptures at the neck during surgery. There is no objective way, device, or tools for predicting rupture of aneurysm so far, but computational fluid dynamics was proposed as a tool to identify the rupture risk. It could give us additional information about this one. About 0.3 to 1% of all intracranial aneurysms compose dorsal wall aneurysm. It's very rare, and they are divided into blood blister-like aneurysm and saccular type aneurysms. And the anterior wall aneurysm as a spatial clinical entity, different from saccular aneurysm on the branching side of internal carotid artery. And computational fluid dynamics, as my colleague mentioned about it, everything about the mechanism. I don't want to stop for each of steps, and I just want to say that in my study we studied computational fluid dynamics changes between correlation between them and between the intraoperative findings, microscopic and endoscopic. And the aim of the study was to assess, identify the correlation between these two parameters. We report a retrospective analysis of 21 patients in Tanzania hospital during a period of 2 years, from 2017 to 19, for internal carotid anterior wall aneurysms. All cases where clipping of aneurysm were performed, CFT, computed tomography, DSA, all investigations were performed. Intraoperative findings such as microscopic and endoscopic examinations were carried out. And out of these 21 patients, 19 cases were found intraoperatively to have a higher risk of rupture based on the thinning of the wall. 2 cases had an atherosclerotic wall, and in this case, we can say that 90% of cases, low wall shear stress was able to predict the potential rupture risk in the near future. This is one case, preoperative findings. We can see the aneurysm of anterior wall. And these are computed fluid dynamics, computational fluid dynamics data. The high pressure and low wall shear stress we can find in this investigation. And here we can find the high oscillatory shear index in the neck part of the aneurysm, and the vector convergence in this part. Intraoperatively, we can find the thinning of the wall of the aneurysm endoscopically and microscopically. The next case is also the anterior wall aneurysm cases. Intraoperative, we can find the thinning of the wall and the low wall shear stress and the high pressure. These parameters, we can say that we have correlation between the intraoperative findings and the computational fluid dynamics parameters. As a result, we can say that low wall shear stress of the aneurysm and high wall pressure, they are correlating associated with thin wall aneurysm and increase the risk of aneurysm rupture. The CFT can be used as a informational additional information to predict the risk of rupture of unruptured aneurysm and for planning of the treatment. Some discussion from the literature. Miura 2010, this group investigated the relationship between the aneurysm dome and oculomotor nerve. In this case, we can see the oculomotor nerve and aneurysm dome. And in this investigation, he gives some definitions. This is a dome, aneurysmal dome. This is a contact zone and contact point. And he said that in this case, showing the contact of the aneurysmal dome and oculomotor nerve has some high pressure, and the streamline flow changes. In this case, we can see the streamline flow around the bleb is going, showing the irregular shape, and the opposite side is showing the linear line. That's this author is concluding that high wall pressure and irregular streamline flow gives us information about the rupture risk. Murayama, as my colleague mentioned before, gives some information about parameters of safety. In some authors, for example, Castro gives a high wall shear stress only, and the other authors gives low wall shear stress can be the prediction for aneurysm rupture. At the conclusion, we can say that CFD and its correlation with intraoperative findings of the aneurysm suggests that the low wall shear stress of the aneurysm wall is associated with thin wall aneurysm and hence increases the risk of aneurysm rupture. The safety can be used to predict the risk of rupture of unruptured aneurysm and for planning of the treatment. Thank you very much.
Okay, thank you. Any very good presentation, Farouz. Any questions or comments from the panel? Let me get you off the screen share there. Hold on. I'll just, okay, that should be it. Okay, any comments or questions from anybody in the panel? Okay, if not, we'll continue on to the next presentation, and thank you very much. Let me get this. Gautam, let me get this presentation. What is the next presentation going to be? I'm sorry, I'm not too organized. Okay.
Can you hear me, Dr. Binoy?
Yes, welcome. Okay, Dr. Binoy, please say a few words about yourself before you launch into your presentation. And welcome and thank you.
Okay. Can you see the screen?
Yes, we can.
Okay, 1 second. Bottom.
You can see me.
Could just.
Okay, I am Dr. Binoy Damodar. I am Assistant Professor of Neurosurgery at Government Medical College, Thrissur, Kerala, India. Okay, and now I am fellow at the Cerebrovascular Surgery at Bantane Hospital.
Excuse me, doctor. Someone has another computer on. I think you have another screen open that we're getting feedback. So close all the programs other than the one you're on, please. We're getting, yes. Okay, I'm gonna. It's okay, we can edit this out.
Okay.
Yes, okay.
I'll be talking on the surgical outcome of unruptured cerebral aneurysms in octogenarians. Why this is selected? Because the risk factors will be differing in the octogenarians. Octogenarians are the patients who are aged between 80 to 89-year-old. So there is controversy. Most of the time, these cases will be treated with the endovascular treatment. But so we want to discuss the okay. I'll be using two terminologies here. One is UCA. UCA is the unruptured cerebral aneurysms. And octogenarians. Octogenarians means it's patients between 80 to 89 years old. The global population is currently aging at an accelerating pace. In developing countries, more than 75% of the people die after 75 years of age. And in Japan, which has the longest life expectancy, female life expectancy was 86 years in 2007. So this is a life expectancy curve. Most of the Western countries like North America and Europe has already crossed the 80 years. But in India, the life expectancy is 68.3. The prevalence of UCA aneurysms is increasing in elderly patients in Japan. Elderly patients with UCS, unruptured cerebral aneurysms, have some intrinsic difficulties, such as decreased life expectancy, increased presence of comorbid disease, increased surgical treatment risk, and poor prognosis for elderly patients with ruptured aneurysms. It was demonstrated that cumulative rates of rupture in the patients more than 8 years of the age were significantly higher than those patients between 70 to 79 years. In patients aged 80 years or older, aneurysms of 7 millimeter or larger and ICPC aneurysms were independent predictors of UCA rupture. Fujita et al. Performed a study to assess the outcome of patients older than 75 years of age in whom ruptured aneurysms were treated by clipping surgery. A total of 333 patients were analyzed. Independent predictors of unfavorable outcome were poor grade and ruptured AC aneurysm. but not age of 80 years or older. Advanced age did not represent a risk factor for poor outcome of clipping surgery in elderly patients. In patients with aneurysmal subarachnoid hemorrhage treated by coil embolization, the patients over 80 years of age were more likely to suffer symptomatic vasospasm when compared with the less than 80 years of age, which has significantly correlated with the worse clinical outcome. Ikawa et al. Did a study to clarify the risk factors of treatment for UC aneurysms in elderly patients more than 65 years of age in Japan. Risk factors for morbidity at discharge were basilar artery aneurysm compared with the IC aneurysm, diabetes mellitus, antiplatelet drug, and anticoagulation drug. However, highest hospital volume compared with the lowest was an inverse risk factor. Sorensen et al. In their study on UC aneurysms found that patients with 80 years had a significantly higher incidence of hypertension and a significantly lower incidence of smoking history and familial aneurysm history. UCS greater than 7 mm carry a non-negligible risk of rupture of 3.2% per patient year. Silva et al. Analyzed the perioperative outcomes of the UCS in elderly patients more than 65-year-old. They found higher prevalence of various comorbidities and the incidence of complications. Clipping patients had perioperative stroke of 10.3%, whereas coiling patients had 3.5%. But this is for the clipping patients had acute renal failure, whereas coiling patients had deep vein thrombosis and pulmonary embolism. So most of these patients have been, for the patients with octogenarians, there are very less studies. Most of the cases are for more than 65 years. And most of the times it is studied for the ruptured aneurysms. So we decided to analyze our experience at Fujita Health University Bantane Hospital. So we did a retrospective study involving all the 33 patients of unruptured cerebral saccular aneurysms operated surgically in elderly patients between 80 and 89 years. We collected the data of all the patients operated between January 2017 and October 2019. Preoperative evaluation, neurological status was evaluated with the Glasgow Coma Score, investigation with the CT angiogram. Patients underwent surgical clipping or bypass surgery depending on the case. Postoperative neurological status was assessed using Glasgow Coma Score and by the presence or absence of the motor weakness of the limbs. These were the comorbidities found in our patients. Hypertension was the most common comorbidity, which was found in 34% of the cases. Other risk factors like cerebral ischemia, diabetes, atherosclerosis, hyperlipidemia, angina, systemic cancer, degenerative spine diseases, antiplatelet anticoagulation medication, previous aneurysm surgery, family history of subarachnoid hemorrhage, smoking, and alcohol. So 31 patients were in the anterior circulation and 2 patients were in the aneurysms were in the posterior circulation. Most common aneurysms were ICPC, which accounted for 10 cases, and MC aneurysm accounted for 10 cases. So surgery was planned for all the cases. All the patients underwent preoperative CFD evaluation, intraoperatively MEP monitoring. We used a microscope, endoscope, intraoperative ICG, and intraoperative Doppler. Results of our studies: we operated 33 aneurysms in 27 patients with a mean age group of 82.4 years. 75% of the patients were females, and the mean size of the aneurysm was 6.57. So results: clipping was done in 32 aneurysms. One case of pica aneurysm underwent occipital artery to pica bypass. Complications were noted. Most common complication was a chronic subdural hematoma in 7 patients, all of which underwent aspiration. One patient had extradural hematoma, which underwent craniotomy and evacuation. One patient with meningitis treated conservatively, and transient lower cranial nerve palsy was occurred in a bypass patient, which was recovered in postoperative period. The mean duration of stay was 16.62 days. The result is that all the patients were discharged with the Glasgow Coma Score of 15/15 without motor weakness of the limbs. Age, sex, risk factors, and comorbid diseases did not influence the outcome of UCS sacral aneurysm in octogenarians. So we conclude that though the octogenarians are at a risk for open surgery for aneurysm, unruptured sacral aneurysms have got good result in tertiary care vascular center in Japan. Hence, advanced age alone should not be considered for preferring coiling against clipping. And octogenarians are more prone for developing postoperative chronic subdural hematoma due to the atrophy of the brain. Thank you.
Okay, Benoit, thank you very much for participating.
Thank you.
Any comments or questions from the panelists? Let me get you off the screen share there. Okay, so we can see face. There we go. Okay, there we go. Okay. Okay, no comments or questions from anybody?
Yes, I have a comment.
Go ahead. Let's see, who's next? Go ahead.
Can you hear me?
Yes, we can hear you.
Yeah, we are very, very concerned about this this message, because when we see an unruptured aneurysm in 80 years old or more, we send him back home and tell him that there is no way that we are helping him by operating. So this is a change of paradigm, what you are saying, because I think that not only in Italy, but everywhere else in the world, 80 years or older patients are not considered for surgery because of statistical, epidemiological concern that we are not offering any benefits. So what is your personal opinion on that?
Sir, all these patients are unruptured aneurysms. So all the cases will be having the neurological status as a 15/15 without any deficits. And if they are fit for the surgery, we should definitely give the option of it. That is the reason there is no much studies on the unruptured aneurysms here. All the studies which are done is on the ruptured aneurysms. That's why we analyze the data. So my opinion is, if the patient is fit for the surgery, we should offer them the surgical option also, because in our case, all the cases improved without any deficits. It is individual. We should individualize the patient, and if we feel that patient is fit for the surgery, we should offer the surgical option also.
I know it would be very hard to digest from the rest of the world, but I would like to comment that patients in Japan are very much healthy, and as you know, they are not as frail as people from in other places. Even they on the next day of surgery, they just walk into your consultation room. Okay, next day of surgery. Age is not a criteria. So you'll be really surprised with the kind of health in real they have.
So we should always, I think we should always individualize the patient. Whichever country it is, if the patient is fit for the surgery, we should give them the option of endovascular and surgery also, because most of the times patients are not affordable for endovascular coiling, but they are affordable for the cheaper surgery, because surgery costs very less amount. So if the results are showing that they have got good results also.
Okay, very good. Okay, let's move on to, thank you very much, Benoit, and I hope you continue to participate. Okay, we're going to start the next presentation. Dr. Satish Kannan is going to be presenting protocol of Fujita Butane Hospital. But before we do that, let's go around to the panel. Satish, we'll be back in a second. Let's introduce everybody one by one. Ricardo, could you please introduce yourself? Are you there, Ricardo?
What I have to do? Introduce yourself.
Go ahead, Ricardo. Please introduce yourself. Go ahead.
Yes, John.
Yeah, please introduce yourself.
Myself. What happened?
Whoop, oh, he left. Okay, go ahead, Gautam. Could you please introduce yourself?
Go, Gautam.
Hello.
Yes, go ahead. Go ahead. Introduce yourself, please.
I'm Dr. Gautam from Bantania Hospital Fellow. I'm doing fellowship here since last 2 months. And I'm a consultant neurosurgeon in Dr. Ella Institute, Chennai.
Okay, welcome.
I think Satish is Satish Kannan is
yeah,
already on.
I think we better move on. Not a smooth production, but it'll work. Okay, welcome, Satish, and it's all yours. Could you please say a few words about yourself and on to your presentation? Are you muted there, Satish? Let me unmute you if you are. Okay. Yeah, unmute yourself there. Go ahead, Satish.
Good evening, everybody. I'm Dr. Satish Kannan from Chennai, India. At the outset, I would like to thank Dr. John Bennett and Professor Kato for giving me this opportunity. A big hi to my friends, Dr. Raja and Dr. Gautam. Without much delay, I will go ahead with my presentation. This was a study which I carried out during my fellowship in Fujita. This is basically use of our protocol of multimodality tools in the safe clipping of unruptured anti-circulation aneurysms. So basically, advances in neuroimaging and its widespread use has led to an increase in the diagnosis of unruptured anti-circulation aneurysms, also known as incidental aneurysms. But the management per se is quite controversial. So the UCAS study in Japan showed that apart from the size, location, and shape, there are other factors which are very much important, which are basically, finally they came to a conclusion that the risk for rupture was significantly higher if the aneurysms were 7 mm or larger, or the location was very important. That is, if they were in the ACOM or in the ICPC location, or when they had a doctor sack as independent risk factors. So these risk factors predicted that apart from size, location, and the aneurysm morphology also plays a role in their rupture rate. So in our study, we used a protocol basically of using multimodality tools, namely indocyanine green with DIVA. I will just explain what DIVA is. DIVA is basically dual image video angiography, which is real-time imaging using, and the same dye is used, but the imaging is in real time so that the anatomy is much clearer when compared to an ICG, which is just a black and white screen. Then we use a neuroendoscope, a 0-degree endoscope, and neuromonitoring MEP is used in all cases, and microdoppler is used in selective cases. So all cases which of anti-circulation aneurysms operated at our institute from 2016 to 18 were taken into account. So basically, we assessed outcome at immediate post-op, at discharge, and at 3 months of follow-up by defining permanent morbidity as a drop in MRS by 1 at 3 months follow-up, and transient morbidity as temporary deficit which improved at the time of discharge. Post-operative events like seizures, infections which did not affect or change the pre-operative MRS were excluded. All patients had a minimum 3 months follow-up before outcome conclusion. So this is basically the Fujita Bantani protocol. So all patients had a pre-operative planning with 4D CTA and CFD as explained by my friend Dr. Gautam. Then after exposure, Sylvian Fisher dissection of the aneurysm is being done. Then routinely an ICG DIVA is done, subsequently followed by an endoscopic evaluation. Then an MEP, baseline MEP is taken up. In certain cases where we are not very clear, we also do a microdoppler evaluation. Subsequently, after clipping, the ICG video angiography DIVA is repeated along with the endoscope and the MEP. If all is fine, the procedure is completed. So this is the CFD which was explained by my friend Dr. Gautam. This is showing that the pressure is very high. The yellow here indicating the pressure is quite high. This is a case of an ACOM aneurysm operated during my period there. And here showing that the wall shear stress is quite low, but the vectors are quite divergent, though not clearly seen in this image. So this is a dual image video angiography image, which is probably one of the most brilliant image to see, where the vessel is very clearly seen along with the all nearby neurovascular structures. Whereas in the case of an ICG, we will not be able to see the nearby neurovascular structures. Thereby, the anatomical correlation is quite much better when we have the DIVA imaging. So here is an illustrative case where figure A shows an aneurysm of the internal carotid artery, then subsequently an ICG image, and subsequently a DIVA image showing the aneurysm with the same dye is used, but the optic nerve and the nearby neurovascular structures are very well seen. This is the advantage of DIVA. And subsequently, after clipping, here we can see the ICG image and the DIVA image showing the flow is much more clear, And here you can see these vessels, the small perforators are well preserved. And at the same time, we can also see the neurovascular structures here, where the optic nerve is seen, where on this side, the optic nerve is not very clearly seen. So DIVA images per se give better anatomical correlation, which are clearly depicted in this image. So this is the 0-degree endoscope, which we routinely used at our Fujita Tanzania hospital. So the second case is again illustrative one of an ICPC aneurysm, where after exposure, the aneurysm is seen. This is the DIVA image. Whereas the routine microscopic image, we are not able to see this perforator. But when you use the endoscope, this perforator is well seen. This helps in planning for this surgical clipping. Now here, the clipping is performed under microscope. Then here again, the clipping, the routine DIVA verification is done. But here, we use the endoscopic to confirm that the clip is not included the perforator, thereby preserving the perforator, which is a very vital step. So endoscopic view is showing that the PCOM is preserved with complete obliteration of the aneurysm. So this, I think, which is very important adjunct using the endoscope. Thereby, we can be very sure that we have not clipped a small perforator, or a small, very so-called not very important perforator. But in this case, we can see it's well preserved. Another thing is that when research is done, on all these patients are basically unruptured patients who come walking to the OPD. So it's very important that they walk out with no morbidities or any sequelae. So this is the demographic data of the last 3 years, with MCA being the most common, subsequently followed by the ACOM. So this is the year-wise summary. In 2016, a total of 98 cases were operated, in majority being MCA, followed by ICPC. There was a drop in MEP in one case with no symptoms, and seizures in one case post-operatively. There was a drop in MEP in a case of ICPC, with the patient had a transient hemiparesis, which improved at the time of discharge, and the transient third nerve palsy in one case. This was the 2017 data, where a total of 119 cases were operated, again MCA being the most common, followed by ICPC. This was the 2018 data, where a total of 130 cases were operated, which again MCA being the most common, followed by ICPC and IC ophthalmic. Seizures were seen in the post-operative period in 3 cases. Transient aphasia was seen in ICA case. So in total, the 2016, a total of 98 cases were operated, with female sex being the most common. Most common was an MCA aneurysm, followed by ICPC. The mean size was 4.8, with no morbidity or mortality or permanent morbidity. Only transient morbidity was seen in 2 cases, that is 2.4%. Again, in 2017, a total of 119 cases were operated, with MCA1 being the most common. The mean size was 6 mm, with no morbidity or mortality. In 2018, a total of 130 cases were operated, with MCA being the most common. The mean size 5.1, with no mortality or permanent morbidity, only in transient morbidity in 0.7%. So this is the total summary. So from 2016 to 2018, a total of 347 cases were operated, with a transient morbidity of 0.9%, with nil permanent morbidity and nil mortality. So summarizing, the mean size was 5.3 in all these cases. There was no mortality or morbidity, only transient morbidity in 0.9% of the cases. So during the initial part of the study, MEP monitoring was done on a selective basis. Subsequently, as the protocol evolved, we have used it in all the cases as mentioned above. Now it has become a routine for all cases. All cases had suture removal done on the 7th post-operative day, and the average hospital stay was 12 to 14 days. So the goal of aneurysm surgery is to achieve satisfactory clipping such that there is no residual filling of the aneurysm. At the same time, without distal branch or perforator occlusion or parent vessel stenosis. As aneurysm remnants have the potential for regrowth and hemorrhage, whereas clip occlusion of the parent artery or small hidden perforators can lead to permanent devastating neurological deficits. Thus, preserving flow in these branches and perforators of the parent artery is very important for a successful aneurysm surgery. So we believe our protocol, which has evolved over a short period of time, provides all the vital information to the operating surgeon, thereby aiding in quicker and better decision making to make microneurosurgical clipping safe, thus consistently resulting in satisfactory operative outcomes and achieving the goal of aneurysm surgery. So in our center, for most unruptured anti-circulation aneurysms, microsurgical clipping is a treatment of choice. We believe our protocol of intraoperative usage of multimodality tools have aided in the safe microsurgical clipping and has consistently resulted in good operative outcomes. So we recommend our Fujita Tanzania protocol in all cases of microsurgical clippings to consistently achieve good operative outcomes. So this was me during my fellowship assisting Professor Kato. This was me again with Professor Kato and Professor Takizawa. The same paper was published in the AJNS for further references. Thank you.
Okay, thank you very much, Satish. Excellent presentation. Comments or questions from? Let me get you off the screen share there, Satish. Hold on. Okay. There you go. Okay. Any questions or comments from the panelists?
I have a comment.
Go ahead.
Yes, Professor.
Satish, we are very in agreement with you when you talk about controlling the perforators with the ICG and the DIVA methodology, but I'm very concerned about what we see when we see ICG for remnants of aneurysm, because sometimes the aneurysm is black, but if you wait, or you move the sac, you can see some filling. And we have the use of puncturing the sac. That is very, very clear method to say if it is closed or not, the aneurysm. Because sometimes I guess that ICG is not so reliable in this option. I mean, for perforators is fantastic, but for aneurysm is not that much. What is your opinion about it?
Professor, I agree the same because they routinely use microdoppler in cases where they are not very clearly able to see the perforators. But in the case of occlusion, I think they go just by the ICG and DIVA. I think we are left with very few options. And I've never, in this study, I've never seen them open up aneurysms and confirming whether there is not any flow.
Hello.
Go ahead, Gautam.
I'm Dr. Gautam. I have a comment on this.
Go ahead.
Regarding what the question by Dr. Paveji, I have been going through the histopathology of the aneurysmal wall, and I have been finding that most of the aneurysm wall receive blood supply, vasa vasorum is dilated in these aneurysms. So the ICG which you see in the later part or after most of the time, if you see though the aneurysm sac is black and then finally enhancing, maybe because of the blood supply to the sac from the outside. So probably this is what my observation when I'm going through the aneurysm wall. There is a wall increase in the size of the wall even after clipping in some aneurysms. So I think this is one of the factors which will give a pseudo effect of the ICG in late stages.
Okay. Any more comments or questions from the panelists?
Thank you.
Okay, thanks everybody for coming, and these will be available as separate videos. All these presentations of each
John,
individual.
Professor Mihawka Kato is there.
Okay, great. Okay, I'm just saying that these videos will be available separately. Okay, onward. Our next presentation is Mihawka Kato, MD. She's going to talk about how to use an absorbable plate for infants. Welcome, Mihawka, and could you please introduce yourself and onward with your presentation. You can hear me, Mihawka? I can't hear you. I don't think your microphone's working here. I don't know. You're not muted.
Yes, she is not muted her speaker.
Hold on. Let me see.
Can you send a message to her?
Hold on, Mihawka. Can you hear us, Mihawka? I don't see a microphone on your system there. Don't worry, we can edit this out. Mihawka, your microphone is not connected to your. Looks like you're not connected to your computer there. Can you hear me, Mihawka? Your microphone's not on. Go to the bottom of your screen to the left. There's a microphone. You have to turn it on. Can you hear me, Mihawka? Yes or no? Okay. Can anybody text Mihawka? Anybody have any?
He has just written
I'm texting her.
there is some poor internet condition, John.
I'm sorry?
Mr. Mikoto has just written in the chat.
Oh, okay. Yeah. Oh, internet connection is bad. Oh, you can hear my voice? Well, your microphone's not even turned on, Mahoko. Even though your connection's not good, it should show up. It's not showing up on my screen here. So at the bottom left of the screen, there should be a microphone and a camera. Do you see that on the bottom left of your screen? Those are your controls for your camera and for your microphone. The bottom left of your screen. Do you see that, Mahoko?
She's not lifting, man.
You have to, or another option, Mahoko, is to reboot your computer. If you reboot, it'll hook up your audio, I think. So let's try that. Okay? Can you do that? Can you hear me, Mahoko? To reboot, turn off your computer completely and come back. Are you talking to her, Gautam? Or no?
Yeah, I'm trying to contact her through phone.
Okay, good. Oh, she's rebooting. That's good. Usually that works with any computer problem. A lot of times I have no idea what's wrong, but it reboots and it fixes it. If in doubt, reboot. Yeah, all these videos will be available probably in a day, separately. Okay, she should be coming in. Just hang on. Okay. Good. Okay, she's coming back. Hello, Noor. Give a shout out to Noor from Pakistan. Okay. Because even though Mahoko's internet connection is not good, her microphone should show up. It won't be the best quality sound, but we do a lot of presentations from Africa where the connections aren't great, but sometimes it works out. We're still waiting for Mahoko.
Hi.
Okay. Yeah, okay.
Yes. We got it.
I'm a genius, man, oh man. Reboot. The only word you have to know in computer repair is reboot.
Yes, thank you, Dr. Bennett.
Okay, let me introduce you. Yeah, let me introduce you formally, okay?
Yes, I'm Miyoko Kato from Japan.
No, hold on. We're gonna edit all this out, okay?
Yes, thank you very much, and good evening. So I'm a neurosurgeon, of course, and my specialty is pediatric neurosurgery. So I'd like to talk about how to use absorbable plates in craniotomy for infants. So if you will operate infant, I hope my presentation is useful. So please, my presentation. What's sorry, please wait.
Share screen.
Yes, share screen.
Yeah.
Oh, wait, sorry.
Yeah, take your time.
Yes.
There you go.
Can you see?
Yes. Yes.
Okay. What?
There you go. Perfect. The perfect.
Yes.
Perfect.
Yes. Okay. Yeah, this is my hospital. So this is Aichi Prefecture Health and Medical Center for Children, suburb of Nagoya. So I want to so.
Yeah, you can make it full screen at the bottom. You had it before at the bottom. It says, yeah.
Yeah, what? So
Keep going. There you go. There you go. There you go. That's it. That's it. You got it. Perfect. Whoa. You had it. Okay.
So,
No.
Yes. So this
It keeps
this
going back.
contains the case and the characteristics of pediatric scar and recommendation for
Yeah,
pediatric.
I'm sure you'll figure it out. I'm sure you'll figure it out.
Plasty.
You had it. That's it. At the full screen to the right there, where the arrows are at. That makes it full screen. At the to the right, the next option at the bottom, next to the plus mark, at the very bottom of the screen. Now keep going to the right. Go to the right to the. There you go. That one, full screen. Go ahead. Click that. Perfect. Oh no, it's not going full screen. Okay, that's good. That's good.
Yes. And so, the case of stroke in childhood, Moyamoya disease and intracranial AV shunt, aneurysm, and so on. And so, Teranja et al. Reported the instance of treated patient with intracranial AV shunt. It was 0.2 per 100,000 persons, 5 years old or younger in Japan. So these patients with AV shunt with managed with endovascular treatment as a first-line therapy, but so sometimes required surgery. So today's contents were case presentation and characteristic of the pediatric scar, and I'm showing our strategy for pediatric patient and recommendation for pediatric cranioplasty. This is a case presentation. This case is a 1.5 months old boy. So when he visited the nearest hospital, he showed left knee paralysis and conversion. CT scanning revealed light ICH. So he was referred to our hospital. Sorry, full screen. And so this is pre-operative 3D CT angiogram, so revealed nidus of AVM. And the removal of ICH. And so we can confirm the post-operative CT. And the pathological diagnosis is it was AVM. So we performed osteoplastic decompression. At the first operation, we performed floating decompression and very stable osteotomy like this. And can you see? And so, however, floating condition induced osteolytic change of decompressive skull. So after decreasing ICP, so elective cranioplasty for fixation was done. So this is the second operation, and finally findings. And so next, I'd like to talk about the characteristic of the pediatric skull. So In the embryology of the skull bolt is intermembranous ossification, the skull base is endochondral ossification. So this is the schema. So skull bolt is intermembranous ossification. So intermembranous ossification occurred during embryonic stage and childhood. So new layer is continuously produced by osteoblast on the external table, and old layer is absorbed on the internal table by osteoclast. In the adult, same ossification occurred, but the turnover is very, very slow. In childhood, especially infant, the turnover is very rapid. So if the plate on the external table, so they will migrate to the intercranial space. And so summary, characteristic of the skull base and ossification speed, it depends on age, and child's skin is very thin and fragile, so we have the acute phase. In acute phase, need to be careful for ulceration and implant exposure, and chronic phase to be careful for scar formation. The osteotomy of pediatric patient will close very rapidly, and also osteolytic rapidly occurred, so especially an infant. And, sorry. Yes, I will explain about our in unity of for skull fixation. Yes, and to consider of the skull growth, we select the fixation material by each case. To avoid skin trouble, we should pay attention for device protrusion. Yes. So what to focus on when choosing plate? So I'd like to compare the titanium plate with absorbable plate. So titanium plate will get strong fixation, but migration to intercranial space. Absorbable plate will not migrate to the intercranial space, but have limitation of fixation force. And so titanium is strong, low cost, and absorbable is high cost. If you want to check post-operative anastomosis for moyamoya disease patient, radiolucency of the absorbable plate is advantage for you. So we should know about each characteristics when selecting absorbable plate. For example, composition, strength preservation period, profile, usability, absorption period, and mechanism. So composition, about composition, there are some type of absorbable plate available. Basic material of this plate is PLLA, which is widely used as a bioabsorbable material. And additional material and production process gives them different characteristics, such as flexibility, strength, and absorption periods. After 3 months, strength is 50% product A, so 90% in product B, 95% product C. It's different. So absorption period is within 1 year is product A. So product B is 3 or 5 years, and product C is 4 or 5 years need. In infant, I choose product A because rapidly absorption and strength is very low. And second, immunity to avoid skin trouble. And this is bicorneal synostosis patient. We perform the cranioplasty osteogenesis please look at the yellow triangle here. The skin, and there is absorbable plate 1 and 2. So the skin of her forehead is very thin. Foreign scar was developed. After then, we changed our strategy. This schema, please look here. So we place absorbable plate on the internal table for forehead. And profile is very important to avoid swollen scar. Plate thickness is different by each 1.9 millimeter over 1.0 millimeter. So screw head also has a different shape. It's very important for children. So this is trigonocephaly due to the metropic synostosis. So we performed cranioplasty for forehead. So please look this picture. So for forehead reshaping, we use plate on the internal table. So this is outside view. You can see the only screws only near the yellow triangle, and the plate is inside. And this is in a case of inappropriate choice. The plate is broken like this. This case is 10 years old. We should select more rigid plate, for example, product C. So in summary, so in infancy, rapid absorbable is recommended. So in childhood, product B should be appropriate because it has moderate absorption speed and strength preservation. And finally, the comment says the selection of absorbable plate should consider depend on the patient age, placement area, and operative procedure. Another idea that the absorbable plate may be used on the internal table to avoid implant skin trouble. Thank you very much for your attention.
Thank you very much, Dr. Cato, for preparing the presentation. Excellent. Okay, any comments or questions? Let me get you off the screen share there, Dr. Cato.
I'm sorry.
That's okay. This is new technology. Don't worry about it. Don't worry about it. Okay, any comments or questions for Dr. Cato? Everyone's quiet. Nor any comments or questions?
Different theme, so.
There's Noor. Go ahead, Noor.
No, hi. Hello. It was a wonderful presentation indeed. I don't think that we actually need any suggestion. Thank you so much for the wonderful presentation.
Could you introduce yourself, Noor? Please introduce yourself. Introduce yourself, Noor.
Oh, I'm Dr. Nurul Damaria, and I'm a chief resident in neurosurgery from Pakistan, working at Punjab Institute of Neurosciences, and working also with a special interest in research. Basically, I'm all the time in the webinars and also in the seminars as well. Thank you.
Very good. Very good. Welcome, Noor. Other comments or questions for Dr. Cato? Yeah, it'll take a while before everyone's used to this kind of a platform. It's a little new to people to feel relaxed. Okay, if not, then I guess we'll wrap it up. Thank you all for presenting, and you'll all get an individual video. We're going to edit it, so you each will have one for your video resume, because you should be building up a video resume. Eventually, we'll be getting CMEs, so it'll be another reason to collect them. So I'll end this formally. You're certainly welcome to stay. And thanks, everybody.
Thank you, John. Hey, Satish, thank you. It was a great talk, Binoy, Satish, and Professor Cato, and Dr. Pavesi. Pavesi has left. Dr. Pavesi, I think, has left.
Yeah, he had left. He have to go to surgery.
Right. It was a
Thank you,
nice
everyone.
time
Thank you.
being here. Thank you. Thank you, everyone. See you again in the next webinar. Merry Christmas and a very, very Happy New Year to everybody.
Same to you.
Thank you to everybody.
Thank you.
Bye-bye.
Thank you so
Bye-bye.
much.
Goodbye.
Bye.
Thank you.
Thank you, everyone. Thanks, Professor
you.
Kato.
Yeah.
Thank
Yes.
you.
Thanks, John. It's
When do you
been a
want to
great
have
pleasure.
another one, Dr. Gautam?
I'll discuss with Professor.
Yeah.
Actually, she's planning for every month, monthly one webinar, something like that.
That would be fantastic.
Yeah.
Just keep in touch.
She was unfortunately today she was unable to attend. She's out
Okay.
of country.
Okay. To see
Tomorrow she will be available.
Okay, to see the videos, they'll be posted on Neurosurgical TV and also on the Facebook account. They'll be posted on the internet. So you will see them either today or tomorrow.
Yes.
Okay?
Yes. Thank you very much. Thank you, everyone.
Okay, thank you.
Thank you. Goodbye.
Thank you
Good night.
so much.
Bye.
Bye. Bye, everyone. Thank you. Bye.
Gitu.
I'm just going to leave the room open if you want to stay or you want to go, whatever. You know, Farouch is gone. Farouch, are you still there? Farouch? Yeah, just unmute yourself, Farouch. You're still muted there. Oh, there you go. Okay.
Are you hearing me?
Yeah. You know,
Yeah, I am Dr. Firuz Shukuru from Uzbekistan, Samarkand city.
yeah. You know, we'd like to organize a conference from that area of the world. Matter of fact, Ipterium was just mentioning that to have a conference for Uzbekistan and Kazakhstan on that area. So if you guys want to get some speakers together, I'll be glad to televise it on Neurosurgical TV.
Okay, John, we'll take into account. Thank you very much.
Yeah, sure, and we're open for any possibilities. Okay.
Thank you for organizing. It was wonderful.
Okay, they're easy to set up. It's not like when you have to organize a conference, you got to rent a hall, you got to do this, this is easy. 1 week, 2 week, boom, you can organize it.
Thank you, John.
Okay, thank you.
Take care.
Bye-bye. Have a good one. Vigneshwar, there's another arrival. Vignesh, can you please, hello, are you still there? Vigneshwar? There's someone we haven't met here. Can enter. So Marco, how's it going?
I'm pretty fine, John. Thank you. I am in Sardinia, in South Italy, with my family for Christmas holidays.
Oh, wow. So you're not working, huh?
Yeah, I have 1 week free.
Wow, on your day off, you come into continuing education.
Yeah, every part of world is as good for neurosurgical education.
Well, you know, we tried to televise Kenya. I don't know if you saw any of it. We really had a hard time. The connection just wasn't. Yeah. They had some good presentations, but unfortunately, I could only rescue like 4 or 5 talks the whole 3 days. I'm like in residency now for neurosurgery, learning this technology and learning. And one thing I found out from this conference was they brought a camera that was not compatible with a high-speed connection. So we were stuck with Wi-Fi and not a very good Wi-Fi. And it was kind of a disaster, but it was a good learning experience. You know, it's like neurosurgery. You learn, you have a case that doesn't go right, but you learn.
Yeah, absolutely. Just consider that some people like Hyperion from Nepal, I would never know him if it was not for neurosurgical TV.
Yeah. You're going to meet more. You're going to meet more too, Marco, as we get stronger. One thing I'm seeing, Marco, it's good to have themes like Dr. Kato just organized this conference. It was good for a theme to have like 7 or 8 talks. Now I can divide all those videos, so they each have one, in their resume. And I think it won't be long before we're getting CMEs, credit credit. You have to get what? We have to get in this country. I think neurosurgeons have to get like 50 credits a year, continuing medical education.
Mm.
You have the same thing, right?
Yeah, we have the ECM, continuing medical education. Yeah.
Yeah. Hopefully, we need to apply for that and go through university. But that will happen eventually.
I know the organization that take care of ECM organization. If you want, I can ask for you.
Definitely. Definitely.
Usually in these courses, there is it could be also done a video, of course, but we need to that every member of faculty write down some questions and to verify the learning.
Right, verify participation.
Verify participation, of course, but also the learning. So there are a list of questions with multiple answer, and you need to answer and if you get a score that is more for 75% of question, your ECM are done.
Right. Yeah. It's getting it organized, and
I can ask for you if you want.
And yeah, because it's a valuable educational experience, and I think if that committee sees the past ones, they'll see it's the same as a conference, essentially.
And it could be very, very interesting and very appreciated from the neurosurgical Italian community, because consider in Italy, I just finished to complete my ECM for the last 3 years. That was 150. But consider that among all the courses I done for get this ECM, just I think 2 was about neurosurgery. The other was about general medicine. And of course, they are very interesting, but do a course about B hepatitis is not my specialty. So I don't know how could be fruitful for me and for my professional career. If I have a course about neurosurgery, I will be happier.
Yeah, it's going to happen. It's definitely happening in some places already. I mean, people get credit for like watching certain videos. They get credit, and certainly if they saw them, if we got it. So please put me in touch with those people. I'd like to follow that. I'm going to do that same in Mexico too, and a couple of different countries. Because I've had some people ask me, "Oh, we give the certificates of participation," but I don't know if that means much really, but I guess to some countries it does mean something that they participated in an educational, although I think legally to get credit, we have to have some kind of approval process and an inspection to see what you're producing.
Correct. Just consider that some courses I did in the abroad, like peripheral surgery, they don't get me credit because they are not recognized for education by the organization in Italy who take care of ACM. So I won't get any credit by my Mayo experience, by my Copenhagen experience about peripheral surgery, but I get with a hepatitis B course.
Yeah.
Strange.
Well, Marco, I'm going to go get a good big cup of Cuban coffee. And I'm going to go, we got to edit these videos now and divide them up, boom, and put titles on them. And we put them in a playlist. Do you know what a playlist is?
Playlist, what is?
It's called a playlist. Now, let me show you. I'm going to show you. This is my job. I'm gonna screen share. Okay, this is our YouTube channel, and you'll understand it once once you see it and why I think it's valuable. Okay, organizing around a theme. Because, excuse me. So what we do on the channel of YouTube for Neurosurgical TV,
Yeah.
we organize what's called a playlist right here, and that puts all like a bunch of presentations in one area. So like, for example, in Cornell, when we did that from New York, we put all the presentations on one page. You see that?
Yeah, yeah, perfect.
Those are all separate presentations. So you can watch, I mean, you know how it is. You don't, when you go to a conference, there's only a couple you want to see. So you just pick out the one you want to see and you watch that, and it goes to the next one.
Oh, it's a great job. It's a
Yeah,
great
see,
job.
we're editing. See how we edited this, and we put the title of the presenter and.
Perfect. It's very useful because sometimes the presentation lasts 1 hour, 1 hour and a half, and if you need to refresh just one topic, you don't need to scroll all over the presentation and find the right one for you. So it's perfect.
Well, you know, one of the things I realized from watching these on a smartphone, if you go to a playlist on the smartphone, you can't sit. On the smartphone, it'll play, and you could understand it. And if you put on the the text option where they have subtitles, you could watch it in a room without even hearing it and just reading it.
Correct.
Because the artificial intelligence is getting better with translation, and soon, I predict within at least 1 or 2 years, you're going to get spontaneous translation of your language to any language.
Correct.
You know it's going to happen. It's going to. Artificial intelligence is getting better and better and better.
Yeah. I think in a far future, the language courses won't be useful anymore.
Yeah, you just have a translator and just immediately.
Correct.
It's going to happen. They're working on it, but I noticed the English because it wasn't too good at first, but now it's really advanced, and even some of the terms in a medical discussion are translated pretty accurately. Not perfect, but you can watch a smartphone. You can watch a conference on your smartphone, one after the other, in a room where you don't need to listen, because sometimes with a smartphone, audio is not too good, but you can certainly watch it and read what he's saying. So you don't have to listen.
Where you must not. There are some places where you cannot put the audio on. So
yeah, you could do it in line at work, at the bank. Just watch a conference. So
correct.
The technology is getting better.
Yeah, and fortunately,
and there's also I'm sorry to bend your ear, but Facebook, I usually televise, like I just televised this on YouTube. Facebook is improving. I can also televise it on Facebook. They're improving their video televising. And I'm going to start exploring that.
Excuse me, John, 1 minute.
Yeah, I better go, Marco, okay?
Okay, don't worry, it's just a phone call. I call later.
Oh, okay.
Anyway, if you're busy, I greet you now, John, and I wish you Merry Christmas.
Yeah, you too. And have a good one. And I'll get those videos done as soon as I can.
Perfect.
See you later.
See you later. Bye.
Bye-bye.